Now, why is that this gentleman, the A, is going to progress in 13 years to end stage renal disease? And why is this gentleman in 43 years going to progress to end stage renal disease? Now, I want you to think why the kidney function remains stable for many years and they only present most of the time when 50% of the kidney function is lost. In India, there was a study done at PGI Chandigarh which said that 5% of cases of end stage kidney disease are because of polycystic kidney disease. It is the fourth leading cause of kidney failure globally. SGLT2 inhibitors can be used in these patients. They are the wonder drugs of 21st century. So I'm sure somebody will come up with a study and say, okay, SGLT2 inhibitors do work.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
So the task given to me by the Medflix team is to talk on autosomal dominant polycystic kidney disease. And as I said on the group, I've kept the talk little interactive, and I would appreciate if you guys can comment in the chat box, and Barsha can probably pitch in whenever somebody is commented on
Yes.
this thing. So polycystic kidney disease is a clinical topic, and I'm going to speak predominantly on the clinical manifestations. I'll speak a little bit on the genetics. I'm not going to dwell too much into the pathogenesis because I think it's remained same. There is nothing new in pathogenesis to update you guys. I'll speak upon the management and the common clinical present extra renal presentations which in patients with autosomal polycystic kidney disease. So to let's start off this session, as you guys do, I love to give explain my presentation with giving examples. So here are two patients who have autosomal dominant polycystic kidneys. Both are 27 years of age. Both are male patients. At the beginning, the EGFR of this particular gentleman, the A column is 91, and on the B column is the same 91. Now, why is that this gentleman, the A, is going to progress in 13 years to end stage renal disease? And why is this gentleman in 43 years going to progress to end stage renal disease? Now, I want you to think why do these two people with the basic same demographic data, one is progressing relatively faster and one is going to progress relatively slow? I'll come to this at a later part of my talk. So, autosomal dominant polycystic kidney disease is a multi-system disease which is characterized by the presence of multiple bilateral renal cysts, and this is also accompanied by cysts in other organs such as the liver, pancreas, the arachnoid membranes. What happens is there is a gradual and a progressive cystic enlargement of the kidneys. Because of these cysts, the kidney gradually deteriorate over a period of time. It is the most common inherited kidney disorder and the most common cystic kidney disorder. It is a ciliopathy which affects the cilia present on the cell surface. The cilia are present on the tubular epithelium, the apical. We know the tubules have a apical side and a basolateral side. These are present on the apical side. Basically, they help in maintaining the differentiated function of the tubular epithelium. As I said, it's a slowly progressive disease where the kidneys go on continues to grow continuously. So most of these patients actually are asymptomatic and they are actually detected on incidental findings. They go for a routine checkup. They are detected to a polycystic kidney disease on a routine screening ultrasound. Pregnant patients, later half of the pregnancy, they come with some, cyst infection, and that's how they are picked up. Many times, we see patients who even deliver and later on follow-up they are detected to have polycystic kidney disease. So the kidney function remains stable for many years and they only present most of the time when 50% of the kidney function is lost. How fast the kidney function deteriorates? So males it deteriorates 5 to 6 ml per minute per year, and in females it deteriorates 4 to 5 ml ml per minute per year. As I said, it's the most common inherited cystic kidney disease. It has a incidence of 1 is to 400 to 1 is to 1000. It contributes to 5 to 10% of ASRD cases worldwide. In India, there was a study done at PJ Chandigarh which said that 5% of cases of end-stage kidney disease are because of polycystic kidney disease. It is the fourth leading cause of kidney failure globally. It is more commonly seen in men as compared to women. Now, as the name suggests, how is ADPKD inherited? It is autosomal dominant. So, example, if the parent has it, there is a 50% chance that it will be transmitted to the offspring. So, if this particular gentleman, the father is affected, there's a possibility one male child and one girl child is going to be affected with the polycystic kidney disease. Now, it is not possible for ADPKD to skip generation. For example, if the children do not have polycystic kidney disease, it's unlikely the grandchildren of this proband case is going to develop polycystic kidney disease. So that this is the conventional and the age-old teaching. Like PKD1 is the gene and it encodes the polycystin 1 protein, and PKD2 gene is which encodes the polycystin 2. But is that it? Well, since we are evolving in our genetic tests, there have been numerous new genes which have been discovered and have been associated with ADPKD like phenotype. This is the Ghana B gene, the DNA JB11, the ALG9. So these are the new genes which we discovered, and these patients have a ADPKD phenotype. They also have a similar finding. The kidneys may have be, probably smaller in size, more cyst. They may be large in size with preserved kidney function. They present with a lot of variation, a lot of phenotypic variation. So this is what I look at. This is a very important tool. Why you should know between ADPKD1 and PKD2. The PKD1 is a much more aggressive disease. PKD2 is a relatively slowly progressive disease. The PKD1 is more common, PKD2 is less common. The average age of a patient progressing to end-stage kidney disease or needing dialysis is around 50 years in patients with PKD1, and they progress to end-stage kidney disease by the age of 70 years in PKD2. There you may see a lot of patients who present for the first time in their 50s and 60s and incidentally detected to have bilateral renal cysts. So they mostly belong to PKD2 and they have a slowly progressive disease. And as I said, the Ghana B and DNA JB11 present slightly differently. Ghana B, the patients have bilateral renal cyst, but the kidney function actually is preserved for a long period of time. And they have polycystic liver disease associated with them, which may be mild to severe. And the DNA JB11, these patients have actually normal size kidney. Conventionally, the ADPKD has got large kidneys. These patients have normal or small size kidneys with numerous cysts. So this is like, phenotypically things are different. ADPKD1 may have large, PKD2 may have large, PKD Ghana and JB11 may have probably normal or, preserved kidney function. That's the phenotypic variation. So what happens exactly? Mutation in PKD1 and 2 leads to loss of the ciliary function of PC1 and PC2, which is, as I said, located on the apical membrane of the tubular epithelium. This leads to decrease in intracellular calcium, which leads to increase in adenylyl cyclase activity. As a result of which, there is increase in CMP in the cell, which activates these numerous pathways, mTOR pathway, STAT3 pathway, and this all leads to cell proliferation. That's how the cysts start begin to increase in number, and there is an increase fluid secretion mediated by the CFTR pathway. As a result of which, there is a lot of these cells are filled with water, and this eventually goes on progressing. So look at the particular red. These are basically increase in polycystic kidney disease, and the green one shows that they are decrease in polycystic kidney disease. Now, this is going to be your, the area of targets of therapy as well. So let's take another case. This is a 43-year-old gentleman with polycystic kidney disease and has CKD stage 5. He presents to follow up with 3 children. The son is 41 years of age, had a renal ultrasound, and it shows no cyst. Now, this gentleman, 43 years, is most likely PKD1. Daughter is 36 years of age, The gentleman is probably older. This is little age is the wrong, inaccurately put. Daughter is 30 years of age. She had a CT scan done, and it shows 15 cysts in each kidney. Son is again probably 29 years of age, had an abdominal MRI with one renal cyst. Now the gentleman comes and asks you, does any of my kids have polycystic kidney disease? The daughter is like, the first option says the daughter has ADPKD, which is quite evident. B is, can you exclude ADPKD in the younger son because he has only one cyst? And C is like, does the patient need an abdominal CT for the older son? So how do you diagnose polycystic kidney disease? Ultrasound, CT, MRI, and genetic testing. These are the four tools which are at our disposal. So how do you screen members? The screening criteria was initially the unified criteria, and now it's the modified Ravine criteria. Uh, Patients who have a positive family history, there is a diagnostic criteria and exclusion criteria. Now, those people between the age of 15 to 29 years of age or 15 to 40 years of age should have three cysts in total. It can be two cysts in one kidney, or one cyst in one kidney, or three cysts in one kidney. They all kind of fall into the diagnostic criteria of polycystic kidney disease. Patients between 40 to 60 years of age should have two cysts in each kidney, and those with 60 years of age should have four cysts in each kidney. Now, remind you, this is in patients with positive family history. In patients with negative family history, how do you diagnose polycystic kidney disease? These patients should have bilateral kidney enlargement and should have 10 cysts in each kidney. If the patients do not fulfill these criteria, they do not classically fit into the diagnosis of polycystic kidney disease, and you need to investigate further. Now, how do you investigate further? One option is you can do an MRI. Now, MRI criteria was also based in patients with positive family history. In those patients where family history is not positive, you need to investigate further using genetic tests. So, what is the MRI criteria? Individuals between 60 to 40 years of age, if they have more than 10 cysts in total, it is sufficient for diagnosis. And those with less than 5 cysts, they are sufficient for exclusion. And this criteria has a significantly higher positive predictive value and a negative predictive value. What are the different imaging? What are the differences between the different imaging modality? Ultrasound can pick up cysts only which are 7 to 10 mm in size. CT and MRI are much more sensitive. They can pick up cysts up to 2 mm in diameter. Ultrasound is cheap. It has no radiation exposure. CT, you may need to give contrast for other things and exposes the patient to radiation. Ultrasound is again cost effective. MRI becomes expensive, and the centers they lack in experience reporting TKV. I'll come to what is TKV. CT has an added advantage of picking up stones, RCCs. Similar is with MRI. And MRI can be used for prognostication of the disease and follow-up. So when do you consider genetic testing? As I said earlier, patients with suspected polycystic kidney disease with no family history. In patients, we know where the imaging findings are unequivocal because you don't know whether this is classically falling in a patient of polycystic kidney disease or not. We use a lot of genetic testing in individuals where we need to consider the younger donors, the members of the family as potential donors in their kidney transplant recipient. And it can also be used for prenatal and pre-implantation genetic diagnosis. The possible indication is like you can do genetic testing, and when you have those when you're suspecting DNA JB11 or Ghana B, it can be used in those indications where you are not, the imaging findings are not very classical of polycystic kidney disease. And up to 8% of patients with suspected ADPKD, they do not have any mutation despite a comprehensive screening. So it's a very variable genotypic picture. So how do you approach a patient with bilateral renal cyst? You may see a patient comes to you, and the most common diagnosis which we see is patients with multiple benign symptoms. This is a very common finding in the population. It is an acquired thing. If you see one or two cysts, see if the patients fulfill those criteria. Most of the times, it's a benign renal cyst. Acquired cystic kidneys is something slightly different. It is seen in older individuals, basically who are CKD5 because of some other cause, or mostly patients who are on dialysis. You may see a lot of patients with multiple cysts in both kidneys. And these acquired cystic kidney disease, there is an increased risk of malignancy in these patients. The simplest way to proceed if you're confused is to go ahead with a CT scan. And based on the Bosniak classification, you can label the patient as simple cyst acquired cystic kidney disease. Well, is it that simple in younger individuals? Actually, no. So there are a lot of syndromes which presents with multiple renal cyst. So the easiest way to go about is you get an imaging done to see if the patient has got renal tumors or not. If there is solid component in it, whether it's an angiomyolipoma or it's a RCC. If it's an angiomyolipoma, they can easily comment based on the Hounsfield units. It's most likely goes in the diagnosis of tuberous sclerosis, and you can confirm it by genetic testing. If it shows an RCC, you need to confirm it by you can do a VHL testing confirmed by the genetic testing. If the patient does not have these solid tumors, you look at the kidney size. If it's enlarged and there is a presence of liver fibrosis, it goes in present favor of autosomal recessive polycystic kidney. No liver fibrosis goes in favor of polycystic kidney disease. There are a lot of various syndromes like Bardet-Biedl syndrome, Joubert syndrome, Senor-Loken syndrome, Michel-Gruber syndrome, which present with a lot of extra renal manifestations. And this slide shows basically how the genetic spectrum differs in various kidney disease. If we see a lot of fibrosis, it means the kidneys are not very large in size. They go in favor of autosomal dominant tubulointerstitial kidney disease. They have a slightly different phenotypic appearance on the ultrasound or the imaging. PKD presents with renal cyst, and if a patient has predominantly liver cyst and occasional renal cyst, they go in the favor of autosomal dominant polycystic kidney disease. So ADPKD kind of overlaps between these two clinical syndromes as well. So as we keep discussing, polycystic kidney disease is not restricted to the kidney. It also has a various extrarenal manifestation. In the kidney, it can present with hypertension, stones, hematuria, nocturia, etc. Extrarenally, most common we see a lot of liver cyst, intracranial aneurysms, cardiac involvement in the form of mitral valve prolapse, a lot of hernias, pancreatic cyst, uh, cyst in the seminal vesicles as well as seen. So if you ask me the most common manifestation in the patient with polycystic kidney disease, that is hypertension. Almost 60% of these patients have hypertension by the time they reach 30 years of age, and even when the kidney function is normal. Now, hypertension is not only detrimental in the progression of kidney disease, it also contributes to the cardiovascular disease in these patients. These patients develop hypertension early in life. They have a fast risk of CKD progression. How do these manifest as cysts? Because cysts compress on the renal vasculature. This leads to upregulation of the renin and eventually the renin angiotensin aldosterone pathway. This which contributes to hypertension. So, but obvious, the drug of choice in these patients is prastoquate, ACE inhibitors or ARVs. This was done long back. It was a very good study done where they showed patients where they see what blood pressure targets are we trying to achieve. So what the HALT PKD programs showed that in individuals who are young, no cardiovascular disease, and they have a fairly preserved GFR, you try going as low as 110 by 70 millimeters of mercury. That is the target which they are trying to achieve. Because if you control blood pressure well, it reduces the risk of CKD, the progression of the cyst. Kidney stones are very common. Surprisingly, uric acid stones are more common in these patients as compared to calcium oxalate stone. Happens because there is a lot of urinary stasis from the expanded cyst, and these are the other risk factors which are responsible for increased stones in the patients with polycystic kidney disease. Now, cyst infection is something which is very difficult for our patients. it increases their morbidity, increases the risk of hospitalization as well, and eventually increases their financial burden as well. Patients generally present with fever, dysuria, hand pain, on where they will have a limited WBC and ARP. The technique to go about here, you try getting an imaging done. Preferably, we see CT or a MRI is better as compared to ultrasound in these cases. After a urine culture is sent, the urine culture may be negative if the infection is just confined to the cyst and the cyst is not communicating with the collecting system. The choice of antibiotics in these patients is basically lipid soluble, like fluoroquinolones. Septran works great. Now, if the fever persists in these patients, the way to investigate is we sometimes have to do a percutaneous aspiration of the cyst and send it for cultures. When the diagnosis is in doubt, PET-CT can be done in this patient. Also, or WBC scan can show increased uptake in the cyst. PET-CT is particularly useful in patients of a renal transplant. The duration of antibiotics in cyst infection is usually 4 to 6 weeks. Although the IDSA strongly doesn't encourage antibiotics for such a long period of time, but for as of now, we generally give it for a period of 4 to 6 weeks. Now, cyst hemorrhage is something very distressing. It is seen in 60% of the patient. It may be confined to the cyst, or the patients may present with gross hematuria. Since the cysts are superficial, if you have a blunt abdominal trauma, they can start bleeding. Now, cyst hemorrhage is very difficult to differentiate from patients with a cyst infection. This is where CT, MRI, PET-CT helps to formulate a differential diagnosis. The hemorrhage is generally resolved within a period of 2 to 7 days. Patients are advised adequate hydration, bed rest, analgesia. Rarely, we need to embolize or even have to sometimes do a nephrectomy if the bleeding is quite significant. It's very it's although we think that these patients may be at an increased risk of malignancy, RCC is not very frequent in polycystic kidney disease, seen in only 1% of the cases. And if it occurs at an earlier age. It is often bilateral, multicentric, and sarcomotor in type. And these are the potential signs you should look if you're suspecting a carcinoma. There is a rapid growth of a cyst, a solid lesion which is detected on CT, or which also has calcifications. Patient has lymphadenopathy, there you present with a tumor, thrombus, etc. As I said, polycystic liver disease is the most common extrarenal manifestation. These generally tend to develop later in life, more common in women, and that's one of the pathology. The concept behind is that women secrete a more estrogen, so the cyst actually in the liver cyst actually respond well to estrogen. So there's a possible higher risk of developing liver cyst in women. I need to understand the cyst in liver do not lead to any enzyme elevation. The most of the symptoms are because of the pressure effect of the cyst. They may press against the diaphragm or the stomach, leading to acid reflux, shortness of breath. The cyst may enlarge in size, which leads to abdominal fullness. The cyst can get infected like a kidney cyst. They may compress from outside, causing jaundice, hepatic venous outflow tract obstruction. Liver failure is unlikely, but we've seen that patients who the liver enlarges significantly, they end up needing a liver transplant as well. Now, how do you treat these patients? Polycystic liver disease, somatostatic analogs like octreotide, lanreotide can be considered, especially in patients with severe volume-related symptoms. But the KDIGO does not give it a good amount of recommendation. It says only 2B. You give it for a period of 6 months, see if there is any response. If not, you need to discontinue somatostatic analogs. You may sometimes need to do a sclerotherapy, embolization, or laparoscopic cyst penetration. Now, IC aneurysms are something which is unique to patients with polycystic kidney disease. In patients who have a family history, it's very common. 25% of these patients have a risk of having an IC aneurysm, and patients who do not have a family history, only 6% have it. Patients generally present with subarachnoid hemorrhage. The classical thing which they teach you is the thunderclap headache, severe nausea, vomiting. There's a high mortality. They rupture early in patients with polycystic kidney disease. How do we tackle them? We see the size of the intracranial aneurysm based on the MRI. If they're less than 7 mm in size, you just need to observe them. 7 to 12 mm, it's again going to be risk assessment. If the patient has a high risk of bleed, we do a coiling or a clipping. If they're more than 12 mm, you need to intervene early. Tobacco and hypertension are strong risk factors. Although these cysts are more commonly located in the anterior circulation, the ones which bleed are more common in the posterior circulation. Now, whom do we screen? Do we need to screen everyone for IC aneurysm? The KDIGO guidelines and most of the guidelines recommend basically you need to screen patients who have a previous history of subarachnoid hemorrhage, patients who have a family history of IC or subarachnoid hemorrhage. If a patient is a high risk occupation like drivers, pilots, they need to be screened. Patient is undergoing to go a major surgery where their blood pressure can fluctuate. Patients who are planned for a kidney transplant, and in patients who want to start anticoagulation from any perspective, these patients need to be screened. So it's not mandatory to screen everyone who come to your OPD with polycystic kidney disease. So the case continues. Now, we diagnosed that the 36-year-old daughter also has polycystic kidney disease. Her creatinine is 1.2. She had one episode of gross hematuria in the past. Her blood pressure has been slightly on the higher side. Urine osmolarity is quite a concentrated, and her urine ACR is 50 milligram per ton. She needs to know like how fast she would progress to end stage kidney disease. Similar to her father, we can't predict, and we need to measure TKV. So this is what we discussed earlier. In the beginning, when the kidney size is maintained, the patients actually are asymptomatic. As the kidneys increase in size, the GFR of the patient starts to decline rapidly. Some of the manifestations like urine concentrated defect, hypertension present quite early, even before the kidneys have started to enlarge in size. So, what are the risk factors for disease progression? 3, 4 main factors. One of the most important factors is a high total kidney volume. Patients who have truncating mutations in PKD1, patients who have had gross episodes of hematuria, patients who start developing proteinuria, elevated copeptine level, and patients who have early onset of hypertension. These are some of the potential risk factors which increase the risk of disease progression. So PKV, as we discussed, is a good tool for monitoring and prognosticating patients with early stages of PKD. It is measured on a MRI or a CT. It actually gives you the exact estimate of the kidney cyst burden, and it correlates with various clinical manifestations like pain, hypertension, hematuria. So as I said, as the TKV increases, the GFR starts to decline rapidly. The CRIS study was one of the original studies done in the past, which showed that patients who have a high total kidney volume, more than 1500 mils, they have a very high risk of progression to end stage kidney disease. Now, how do you measure the TKV? This came via Mayo Clinic has done a lot of work on ADPKD. So they put in the specific dimensions. They measure the sagittal length, measure the coronal length, and measure the width, and they put it in this particular calculator. Based on this calculator, they made various stages: 1A, B, C, D, E. So what they found, patients who fall in the criteria of 1C, 1D, or 1E, they have a very rapid progression to end stage kidney disease. So our patient, she presented in the criteria 1E. That means she has a risk of progression to end stage renal disease in 12 years by the age of 40. That is practically same as that of her father. The advantage of doing MRI is you can pick up a lot of atypical polycystic kidney disease patients as well. However, the height adjusted PKV is not standardized in these patients. So you cannot predict the decline on GFR in these atypical cases of polycystic kidney disease. That's the caveat of HTKV in atypical PKD. This is another useful tool. It's the PKD score by different criteria I mentioned. Like if you are a male, you get 1 point. Hypertension before 35, you get 2 points. First urological event like hematuria, you get 2 points. Similarly, so forth. Now, if you have a score of 0 to 3, you have a very low risk of progression to ESRD. 4 to 6 have an intermediate risk, and patients with 7 to 9 have a high risk of progression to ESKD. And this was the answer to my first slide. Remember, I showed you two patients, males, 29 years of age, initial EGFR. One was progressing very fast, one was progressing very rapidly. Now, I didn't give you the other hint factors, what the pro-PKD score is. Similarly, look at these cases, everyone has a different phenotype, age, whether they have truncating mutation, whether they have onset of hypertension, urological event, uh, the TKV. So all these are potential risk factors. Hence, it's a very variable phenotypic disease. Some patients may progress rapidly, some patients may progress slowly. Now she knows, she has a very rapidly progressive disease, and she would like to know how can we retard the progression of a kidney disease. What would we advise her? Water prescription. We advise a diet. Do we give a Tolvaptan? We do a tight blood pressure control, as we said earlier, or we use all of the above. This is a very useful flowchart, which I feel. Once you have polycystic kidney disease, you can have either have a typical disease or you can have a typical disease. Or typical is the one where we said, the kidney size may be variable, they may be normal, etc. In general, how do you manage these patients? You put them on a diet which is low in salt, a moderate protein restriction. I won't restrict the protein too much. We ask the patient to stop smoking. They can resume an exercise but avoid contact sports, reduce their weight, because these patient obesity, smoking, as we discussed earlier, there are risk factors for progression of kidney disease. So these are the basic tools for management in general of any patients with kidney disease. Also, if patients who have typical PKD, we measure the kidney volume TKV by the MRI criteria, and we see whether they fall into which class. If they fall into class A or B, they just follow the standard rule. If they fall into class 1C, D, E, they can be initiated on disease modifying treatment. Now, how does water prescription help in reducing the progress of kidney disease? If you go back to the initial pathogenesis slide where I've showed you, there is upregulation of the AVP pathway. There is increased vasopressin secretion. The vasopressin basically stimulates the cyst growth by increasing fluid accumulation in the cyst. So what we ask a patient is to drink a lot of water. By drinking a lot of water, you suppress vasopressin in the body. This is generally recommended in patients who have a barely preserved EGFR. We generally tell them to drink at least 2 to 2.5 liters of water per day. We ask them to drink plain water. Don't drink sugar-containing beverages because they have an increased fructose, which increases to oxalate as well as uric acid stones. However, it's not advised in patients with advanced stages of kidney disease, because it can lead to water accumulation. Now, how do we give them a water prescription? This is actually a beautiful slide which I took from one of the presentations. You need to achieve a urine osmolarity of less than 280. You do that by asking the patient to restrict salt, restrict a little bit of protein, and increase their water intake. So we calculate the 24-hour urine volume, and we calculate the urine osmolarity and divide it by 280. And based on that, we can give a patient a rough estimate how much water should they be drinking. Now, what is the pharmacology? What are the drugs we have at our disposal? So these three drugs basically act by reducing the cyst proliferation and the fluid accumulation. Tolvaptan is one of the main drugs, as I showed earlier. It blocks the V2 receptors, prevents the water from entering the cell. Somatostatin also binds to its receptor and prevents cyst proliferation. mTOR inhibitors only reduce the cyst size, but unfortunately, they are no longer recommended by most of our guidelines. So tolvaptan was initially studied in patients with fairly preserved kidney function, those with a EGFR of more than 16. And this particular tempo study showed that tolvaptan not only decreased the rate of TKV, the size of the kidney, increase in the size of the kidney, but also reduced the decline in the kidney function. So it helped to preserve the GFR as compared to the standard of care, that is just what we discussed earlier. So people said, okay, fine, you've done it in normal patients. Now, what about patients who actually have kidney disease? So they did the study in patients with poor GFR, those between eGFR between 25 to 65. And they found even in this subgroup of patients, tolvaptan helped in reducing the TKV and it slowed the risk of progression of kidney disease. So, what are the indicators? As we discussed earlier, patients who have a high peak, on the MRI, they have a 1 CDE, they have a high pro PKD score. Patients who have a USG length showing a kidney of more than 16.5 centimeter, and patients who have a rapidly deteriorating renal function. You see the patient at 6 months and you see, okay, fine, the GFR is deteriorating very fast. These patients actually benefit when you start tolvaptan early. Now, prescribing tolvaptan is art. Now, most of you feel tolvaptan is used in hyponatremia. However, FD does not approve the rule use of tolvaptan in hyponatremia. It recommends in patients with SID it's only for a period of 1 month. The tolvaptan is actually the drug which is first used in more commonly used in patients with polycystic kidney disease. The trials dosed it at, the patients were given 45 milligrams in the morning and 15 milligrams at night. But the problem is, like, we don't usually start patients at such a high dose. One, most important is the cost in our country. Secondly, we do not know how compliant the patients are going to be water therapy, because if we are asking them to take tolvaptan, they're going to get dehydrated very fast. So you need to see how they are tolerating these medicines. Another most common dangerous side effect of tolvaptan, it can cause idiosyncratic liver injury. You can see a 3 times upper elevation of the liver enzymes. So what I recommend my patients is you start at 15 milligrams, see how they're doing at 1 month, check their LFTs, go up to 30 milligrams, go up to 45 milligrams, then add 50 milligram a night, and gradually you keep monitoring the LFTs along with it. Important thing is you ask these patients to hold tolvaptan if they are sick, if they're not feeling well, have fever, vomiting, etc. Tolvaptan shouldn't be initiated in patients with those who EGFR of less than 25. It's not going to be very effective. Those with urinary tract obstruction, it's not recommended in patients with pregnancy, breastfeeding, etc. As I said earlier, somatostatin analogs like lanreotide has been approved only in patients with PKD who have associated liver cyst, because it it is not very effective in reducing the cyst progression and the EGFR decline. The Aladdin trial, which was the trial which showed how it worked, it significantly reduced the TKV growth after 1 year, but it did not have any effect after that. mTOR have completely been phased out. No longer they're being recommended. Something which is very common, PKD in pregnancy. The thing is, polycystic kidney disease is one of the favorable disease in pregnancy. Most of the patients actually go through pregnancy even without being detected with PKD. So, in general, what is the management approach? If you're pregnant, we with polycystic kidneys, we give the option to our patients at that time. We tell them, okay, yes, you have a 50% risk of transmitting your disease to your newborn. So it's going to be their call. We can do amniocentesis or CVS and send the sample for genetic testing and see if the fetus is affected or not. If the patients are on RAS blockade, we discontinue tolvaptan. We need to explain all our patients there is a potential risk of PIH, there's a risk of preeclampsia, IUGR, all those complications are going to happen. How do we manage them during the pregnancy? The most three things which we see in a patients are we monitor their blood pressure. Target blood pressure is anything less than 140, 120 to 140 is a target. We keep a look on their if they are having proteinuria. Start aspirin at 12 to 14 weeks to reduce the risk of eclampsia. If these patients are having, we monitor them for urinary tract infection because the cyst may get infected. And post pregnancy, during the lactation period, again, tolvaptan and RAS blockers are avoided. Once there's after 6 months not breastfeeding, we can restart them. There is also increased risk of ectopic pregnancy in these patients with polycystic kidney disease because there is maybe mutation in the cilia and the fallopian tubes. Dialysis and polycystic kidney disease. So should hemo be preferred over peritoneal dialysis polycystic disease? Many people feel, okay, peritoneal dialysis, you're going to fill fluid in the belly. These patients already have enlarged kidneys with possible cyst infection can give rise to peritonitis. and they may not accumulate a large amount of fluid. Also, there is an increase in the abdominal pressure, which can increase the risk of hernia. However, a meta-analysis showed there is actually no difference between PD and HD. It all depends on the patient-related factor, what the patient wants, and availability of the facilities. If you don't have facilities in your center to handle PD peritonitis or hernias, then it's best to put these patients on hemodialysis. Transplant remains the final ends goal for all patients with polycystic kidney disease. These patients actually do very well once they receive a allograft from a living or a cadaveric donor. There is no risk of recurrence because these kidneys are never going to be taken from a patient because the mutation is in the kidney, not in anywhere else in the body. So there are three essential aspects for evaluation in a patient with PKD. We look when should we remove the native kidney. If there is a recurrent infections happening, if there is no space to accommodate the kidney graft, if we are suspecting a malignancy, patients are getting recurrently infected, hemorrhage, these are potential indications where we may consider native nephrectomy prior to the transplant surgery or at the time of transplant surgery. It depends center to center. We look for IC aneurysm. We also look at liver involvement. We need to be sure that the patient does not need a simultaneous liver or kidney transplant, because it should not happen. You transplant only the kidney and the liver deteriorates over a period of time rapidly, and then you may need another liver transplant. This is a specific criteria. How do we choose living related donors from the family? uh, if the patients have less than one cyst based on the ultrasound by the age of 40, I'm sure we can take them. If when we are unclear, we proceed with the MRI, and when the diagnosis is still equivocal, we go for genetic testing. So to summarize, polycystic kidney disease is because of defect in PKD1 and PKD2. Newer mutations are also responsible for the ADPKD like phenotype. Ultrasound is the first and the initial tool used for screening of family members. MRI can be used if the ultrasound findings are not significant or not pinpointing towards polycystic kidney disease. Genetic test is the most definitive way to go about diagnosing polycystic kidney disease, but still, as I said earlier, 8% of patients may not have a genetic mutation. General treatment remains the same: blood pressure control, target a low BP in younger individuals. You need to assess patients who have a rapid risk of disease progression and consider them for Tolvaptan. Tolvaptan is the current therapy of choice in patients with polycystic kidney disease, but it comes with its own side effects and interactions. With that, I will sum up my case and I look forward for any questions.
Thank you, sir, for that wonderful presentation. We do have a lot of doubts coming in from our doctors. Sir, I'm taking one of the earlier questions that we had.
Yeah, so
This is from Dr. Chulo. What are the complications of cortical renal cyst growing over a long period of time with normal renal function?
So I said, these cyst ones, if they keep growing over a period of time, they can eventually lead to deterioration of renal function. That's what we are most concerned at in a patient. We want to avoid them from going into end-stage kidney disease. The cyst can get infected, which is any any point of time they can. You can have cyst hemorrhage, chronic pain. That's something which I didn't address because it's something which is very complex. So these are few of the the complications which we expect when the if the cysts are growing over a long period of time. Some patients may remain absolutely asymptomatic as well. That's a stroke of luck, but most of them, 80% of them do develop some or the other, manifestation. And always, these patients develop hypertension also.
Next from Dr. Chaitanya, what is the prognosis of angiolipoma with normal renal?
Angiolipoma is like absolutely a benign finding. You may see a lot of patients who come to our OPD. We see them from having angiomyolipoma. We just do a CT scan. We see if there is no potential malignant features, and that's it. Sometimes these patients, we just warn them, if you ever notice of hematuria, significant back pain, just go and meet your doctor because you may need to get a CT at that point of time. But most of them, we just ask them to avoid contact sports. Sometimes my boss used to always tell, he had a patient who had used to do the hula loop, and she had injured her kidneys on the angiolipoma bled. So that's one rare of thing which can happen with angiolipoma. Otherwise, it's a very benign find. We even consider patients, we can remove the angiolipoma at the time of transplant surgery in the donors, and we can use those kidneys for transplantation. We had a patient for that, like similar case.
Next from Dr. Bhatt, if uric acid stones are more seen more frequently than calcium, will they also be present with gout?
Yeah,
Or
they do. Yeah. So gout is a very common finding in any CKD patient, and as so pointed out, absolutely, we do see a lot of gout. But the trick is like any patient of CKD, and if you see if a patient has asymptomatic hyperuricemia, we don't treat hyperuricemia. We see a lot of patients, unnecessarily prescribe febuxostat or Xyloric, even if their uric acid goes up to 8. The indication of treatment is only if you have recurrent uric acid stone and in patients who have gout flares. These are the only two indications where you keep them on this particular febuxostat or allopurinol. Oxalate stone basically it's a calcium oxalate stone. Phosphate stones can occur, if you develop a big staghorn calculus, you can have a triple phosphate stone.
so taking the next question from Dr. Kulkarni, do you think renal hypertension is the culprit for polycystic kidney disease?
Basically, hypertension, we all know, in any form of kidney disease is a risk factor for CKD progression. That's one of the goals of treatment of any form of kidney disease, whether it's diabetes, blood pressure, IgA nephropathy, lupus. Our aim is always to keep the blood pressure well controlled. So hypertension per se is not the only risk factor, but it is one of the risk factors for any kidney disease progression. And as
Next
I said,
question
it's
from
because of the
Dr.
RAS
Deora.
activation. RAS gets activated, aldosterone gets upregulated, leads to a lot of fibrosis in the kidney as well as in the heart.
So taking the next question from Dr. Deora, how much percentage of cases of ADPKD develop CKD in an untreated case? Can ACI and ARB therapy be combined in hypertension induced by ADPKD?
So first half of the question is like how many percentage of kidney patients with polycystic kidney disease progress really rapidly. So yeah, if the patient has PKD1, they will progress fairly rapidly to end-stage renal disease. Depends upon the other risk factors as well. ACE and ARBs. So there have been few studies which have been used in the management of they've combined ACE inhibitors and ARB. HALT PKD, the second version, had some patients who had both ACE ARBs. There have been used studies like there were also studies in membranous nephropathy like altitude, VA, nephron, where they've combined use of ACE inhibitors and ARBs. Now, we usually don't recommend patients who are on dual RAS blockade. However, there have been, some instances like where patients have been put. Many nephrologists, senior nephrologists, back in those days when they do not have significant medication, they were on ACE inhibitors and ARB. Professor Mani from Apollo Chennai is a very senior nephrologist. Her used to use a lot of patients, have patients on ACE inhibitors as well as ARBs. But I personally am not very comfortable because there's a very high risk of hyperkalemia. That's what I'm worried about. So I wouldn't prefer, probably use RAS blocker to its maximum role, probably add calcium channel blocker. Diuretics we don't prefer, beta blockers, and probably then, comes the alpha blockers.
There's another question from Dr. Deora. Can ADPKD be associated with PCOD as an external
Not
manifestation?
reported, it's not reported as such. No, it's not one of the manifestations of ADPKD.
Next is from Dr. Kumar. What is the survival period after arterial
Survival is excellent. Like it's similar to any. In fact, the best part of polycystic kidney disease, like the disease does not recur in the transplant kidney. Patients with glomerular disease like IgA, patients with FSGS, they have a high risk of recurrence. So the transplant kidney goes away because of the risk of recurrence. So the risk of recurrence is kind of practically omitted. So these patients have a fairly good survival once they get a good kidney from a young donor or anyone. Mostly we see a lot of in India. It's mostly the spousal donors who donate in patients with polycystic kidney disease.
Dr. Agarwal says your experience in retarding the progression with Tolvaptan as shown in the TEMPO trial. Do they have side effects?
Okay, my experiences. See, don't have patients who've been on Tolvaptan for a very long period of time. A couple of them, only a very handful of Indian patients go up to the maximum tolerated dose of Tolvaptan. One. You need to follow up these patients for a very long period of time, like 5 6 years. And like, so I don't think so. I don't have that cohort of patients where they've been on tolvaptan for a long period of time. I'll be honest, I start tolvaptan very early. I feel I don't wait for the, because most of the centers in India do not know how to report the Mayo protocol. They do not know how to report it as 1 CDE. We need to go and speak to a radiologist, go and give the TKV. So I can't wait for the TKV to come back after so many discussions with the radiologist. I generally start them on tolvaptan pretty early, 15 milligram, because that's the kidney function is maintained. The tempo 3 4 trial clearly show that you can give in patients with EGFR more than 60. So I preferably start early. See if the patients are affording or not. That's the major limitation of tolvaptan. It's a very expensive drug. Oh, here abroad, everywhere it's very expensive. So even if the patients are affording, we keep going on the tolvaptan dose. A newer study shows that tolvaptan, you don't need to give it as per the tempo trial. They say even with a dose of 45 and 15, if your urine osmolarity comes down to 270, 280, you've done the job. So you don't need to go up on the dose. Side effect of tolvaptan is, I think so, liver toxicity. We had a patient where we started tolvaptan to the patient. The previous ultrasound did not comment on the liver. We said, okay, fine. When the patient came back for a follow-up, he had a 3 times upper limit elevation of the liver enzymes. And when we screened the liver again, it had features of some early chronic liver disease. So we totally omitted tolvaptan in him. So tolvaptan, the major side effect is the liver enzyme elevation and the dehydration which occurs with tolvaptan.
Does SGLT2 inhibitors have any
Yeah.
according to progression?
So the so if any of you want to go, KDIGO guidelines, they come up with a research consensus statement as well as a guideline just a few weeks back. So some of the slides are taken from the KDIGO guideline. So KDIGO still does not approve SGLT2 inhibitors in patients with PKD. But there are ongoing studies which may start showing SGLT2 inhibitors can be used in these patients. They are the wonder drugs of 21st century. So I'm sure somebody will come up with a study and say, okay, SGLT2 inhibitors do work. So the guidelines can keep changing at some point of time. So as of now, there no strong recommendation, but at some point of time we may have benefit with them.
So that is it for the questions. Thank you for taking in all the doubts from our doctors. And with that, I'd also like to mention that there's a lot of appreciation for your teaching and for your presentation. Our doctors really seem to have loved it. And thank you once again, sir, for doing this session with us. We hope to see you soon on Netflix, sir. Thank you once again, sir, for this session.
Thank you. Bye.